Good evening. Thank you very much for sticking around after a long day of presentations. My name is Dr. Marianne Dubard Gault. I trained in preventive medicine, medical oncology, and genetics. I am an early cancer detection doctor, and my goal is to detect cancer early and/or to prevent it if possible, especially if it is a genetic cancer. Today, I will share a story with you on one of our projects to increase access to genetic testing for cancer care. First, we'll go over data and background and numbers that I'm sure you're all familiar with, and we'll share a little bit about our pilot and the results, limitations, and future directions. Before I do this, though, I want to share a little bit around the background on how I got here. When I was training in oncology, I saw firsthand the gap between academic medicine and community oncology practice. I had read about the immediate and long-term benefits of identifying BRCA1 and 2 carriers, and yet out of 100 patients 50 years and younger with triple-negative breast cancer in my clinic between 2005 and 2010, only a handful received genetic testing. This drove me to train in genetics and focus my research on bridging this gap, so every patient diagnosed with cancer has access to genetic testing wherever they receive care. Our partnership with Olympic Medical Center is an extension of this work to help identify things that help make genetic testing easier to access. One of the landmark papers I'll share with you today is this one. This is a study where Dr. Samatar et al. Offered genetic testing to every single patient with cancer at their institution at Mayo Clinic between 2018 and 2020. They tested almost 3,000 patients. Mean age was 62, 30% had a family history of cancer, and 50% had an advanced cancer diagnosis. What they found was that 13% of patients had a genetic predisposition, and they highlighted things we already knew, that a subset of patients with breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer have a genetic predisposition to cancer. But they also highlighted things we didn't know as much about regarding bladder cancer, head and neck or lung cancer, and even hepatocellular carcinoma, liver cancer. So this is a common this is a common finding in your clinic, and many of your patients may already have genetic predispositions that we're not identifying. So that is one of the main reasons cancer genetic testing has been recommended by many national guideline making committees. And one of the other reasons for why it is really important to have genetic testing is that it changes or improves outcomes. This is a study for the Olympia clinical trial for patients with BRCA1 and 2. They offered people who developed breast cancer and had a germline BRCA1 and 2 were offered 1 year of adjuvant olaparib, a PARP inhibitor, after they completed their treatments. And you see a clear separation of the curves between the people who received olaparib versus placebo, highlighting how much this is an improvement in overall survival for cancer care. So overall, we see one of the most important evolution of a decade for breast cancer, that adjuvant olaparib improves overall survival for people with a germline BRCA1 or 2 when they develop breast cancer. And so why are we not then testing patients? So yet patients with cancer are not always offered genetic testing when they meet criteria. This is a study that was done by Dr. Alison Kurian at Stanford, where she looked at registry data for how many patients with breast and ovarian cancer had genetic testing. And she found that a quarter, so one-fourth of patients with breast cancer had genetic testing for breast cancer. And you see the purple line there, that is for people receiving testing, either BRCA1 or 2 or a multi-gene panel. And for ovarian cancer, it was 1/3. So I could share many more reports here and data, but I would like to focus on why and how do we improve. First, I'll give you a little bit of background in the geography for our area. So we live on the Pacific Northwest in the United States. We have, in the state of Washington, 39 counties, and patients can come to multiple different locations for their cancer care in the Seattle area. We also partner with multiple states across the Pacific Northwest, and the one important one here will be the #1 Olympic Medical Center in Sequim. That is who we partner with for this study. And I would like to also give credit for all the team that participated, Dr. Marcienko, Kevin Weeks, and Jose Ruiz Bonilla, out of many other ones. The team helping get patients through having their chemo infusion and many other treatments and receiving genetic testing. So this study was a pilot award from the NIH P30 grant from the Fred Hutchinson Cancer Consortium. The grant funded the time for a bi-monthly review of 3 months for documentation of genetic testing and other information, and also covered the genetic testing for the patients, so we didn't have to go through their insurance. There was strong support from leadership to be able to do this work. And I'll go over the details. So we included patients with breast, ovarian, pancreatic, and prostate cancer. We excluded people with DCIS and high-grade polyps. Our initial kickoff meeting was right before, in the middle of the pandemic, May 21st, 2020. We had a 3-month observation phase where we did not do coaching and just measured the number of patients seen, the testing ordered, and the indication for testing. And we had an intervention phase during the Delta wave, and that will be important later on. Well, we did bi-monthly meeting, review of cases, and helped coach for indication for genetic testing. The community oncologist asked if we could extend the phase where we offered genetic testing to patients until October 31st, as there were many delays for cancer care. And then we also wanted to make the life of the staff helping patients get genetic testing there easier, because many staff members do not have access to training in genetics or to the NCCN guidelines, and the NCCN guidelines are quite complicated to follow every 6 months. So we made a simplified table for them to have and to offer testing to every patient with ovarian cancer, pancreatic cancer, metastatic prostate cancer, and many other indications. This is our table 1, or the demographic data of our paper or study. So we have 415 patients in phase 1. Almost 2/3 was sex female documented in the chart, and mean age was around 70-year-old. This will be important later on as well. Most of the people were of white ancestry. We had mainly people diagnosed with breast cancer, and then we had 35 patients diagnosed with ovarian cancer and 19 patients diagnosed with pancreatic cancer. And remember, all should be offered genetic testing. And we had about a large proportion of people where the stage of their cancer was unknown, mostly because it was not in the review or the reports we received at our study team, and maybe documented in the chart in a different location. So this is really important here. Of the 100 patients who met criteria for genetic testing in phase 1, 29 received testing. Phase 2 happened during the Delta wave, so that's why there's less patients. And of the 48 patients in phase 2, 25 received genetic testing, highlighting that 70% of people meeting genetic testing criteria did not receive testing. When we looked at the type of cancer, 1 in 5 people with pancreatic cancer did receive genetic testing, and 1 in 6 for ovarian cancer. For prostate cancer, it was the lowest group tested, although there are other studies where patients can sign up for genetic testing. And we had shared a family history tool to help document family history that was not used by the oncologist because they were already documenting in their chart note. And often there was no documentation in the chart note about family history. So yes, we increased the number of patients tested by 23%, from 29 in phase 1 to 25 in phase 2. But we did not help increase documentation of family history. For example, here you see no information about family history in phase 1 for 57.6% and then 57.1% in phase 2. So this is important, because if knowing whether a patient meets criteria depends on the family history, and you do not have the family history, you will miss the patient. And we know that between 30 and 50% of patients who meet criteria don't meet criteria because of their family history. And some patients do not know their family history. So maybe we would consider removing the family history questionnaire or information from the guidelines altogether. I went back at our own main campus data, and so we mentioned that 1 in 5 patients were tested for pancreatic cancer. And how did we do at main campus? This is a dashboard that one of our students in a Master's of Public Health helped us develop and have. And you see here that we can look at a window of time between January 1st, 2020 and 2023, I'll show you a little bit more in details here. You can look at all the sites of practice. You can look at all the C25 codes for pancreatic cancer, exocrine specifically, and you can look at what happened to the patients. So we have of 1,000 patients who were eligible to be genetically tested. I was really hoping we would find 100% or 1,000 tested. And we found that about 221 patients were referred. I know a lot more patients were referred, but were already tested at an outside institution, so we're considered we're closed. So we were closer to 500 patients referred altogether, and we were closer to 500 patients tested altogether. Although here in the chart you have only 283 patients seen because patients had received their genetic testing at an outside institution before coming. And then you can see here where the filters, you can see the age at first appointment, the breakdown between male and female, and the ethnicity or who the payer for their care is. All right, so what did we learn from this study? We learned a couple of things. One was that support from leadership and dedicated or protected time was very important for this study. We were not testing 100% of patients who should be offered testing. Coaching helped bring information top of mind for the doctors during our conversations. But there were many criteria, multiple options for genetic testing, less documentation of the family history, and limited time. So having a catch-it mechanism to do testing every time is necessary. Having a systematic way to identify patients who meet NCCN criteria, add a cancer diagnosis, and incorporate the genetic testing right off the bat as part of the staging workup is really, really important. Point of care testing for all patients without relying on a nurse, and MD placing a referral will make all the difference. Limitations of the study here, median age was 10 years older, so a lot of the family history was missing. Documentation was key. Having one place where everything is would be really important. So the staging workup, the path report, easily ordering genetic testing through the portal into the medical record would be much easier. And the cost of the testing or the cost of follow-up care when people were found positive was a limiting factor as well. All right, future directions for where we would like to go. So having one test instead of having multiple options would be useful, and one test that would test the tumor and the germline at the same time would be the best way to go. Patients and doctors may not always know the difference between a test that was done 10 years ago and needs to be upgraded. Testing, like everything else, needs to be upgraded, right? And or testing that was done by a commercial laboratory that only looks at 3 or a few mutations rather than a whole comprehensive set. Another solution is to have one place where everything is located. So this is an expensive solution, but one that is worth the investment down the road. You have everything in one place, the path report, the stage information, the genetic testing, the prognostic tool like Oncotype DX, and many of the tracking mechanisms for minimal residual disease could be all located in one place. And then maybe simplifying the guidelines altogether, removing the family history and focusing on the cancer diagnosis, having an easier way to counsel patient before they get their initial appointment for breast cancer or other cancers, to have someone dedicated to tracking the results, making sure they were reviewed and discussed with the patients, and then referral for high-risk care when that is needed. And then other future directions, and this is something our group has worked on, is develop a best practice guideline for how do we identify all patients at a cancer center who should be identified and offer them genetic testing. This accounts for a significant number of the population, and we could very well imagine an online remote genetics tumor board where you have an on-site navigator nurse, for example, who would help get the genetic testing done, and we could have telemedicine to help with consultations if needed. And can we then develop a partnership with a nurse practitioner locally to help identify patients or family members who need screening and surveillance going forward? So this is a family where I highlighted here all the patients highlighted under the blue are eligible for screening for pancreatic cancer, for example. And we could very well, if we had locally some support, to be able to do testing and screening for all of these patients in this family. And on this, I will end with saying it matters we identify cancer syndromes for multiple reasons for people active with active cancer and people unaffected at risk of cancer. So people active cancer diagnosis, it's important for their treatment sequence. Do they need surgery first and an adjuvant chemotherapy second, or vice versa? The choice of therapy, do they need a PARP inhibitor versus an immunotherapy medication? The prediction of response, if you have MSI, you would probably do better with an immunotherapy medication rather than something different. The risk of recurrence, if you have a risk of a second primary breast cancer, that's important, but knowing also if your risk of breast cancer to come back is important as well. The prognosis, the risk of overall survival and prognosis from your cancer diagnosis, and the risk of multiple cancers for both groups, right? For a risk of ovarian cancer and pancreatic cancer down the road. And this is also important for the unaffected relatives, where you could do cancer risk screening and assessment, screening and early detection to catch a cancer early, risk reduction by removing ovaries, for example, and prevention if we can, and then for better outcomes for family members. And on that, I will, I think this is my last slide. I will thank you very much for your attention. Thank you for listening. This work was funded by the P30 NCI grant of Fred Hutchinson Cancer Consortium. You see here my email and my Twitter handle, and a QR code for an evaluation. If you would be so kind, I would really appreciate it. Thank you very much.